immense personal, oh, sorry, okay, immense personal satisfaction in being able to help your patient and those who love him or her. I'm going to be talking today about medication for opioid use disorder and making it practical for your practice. Are you too busy to provide treatment for OUD? I know many of us have felt that we are, and I thought I was too. But the truth of the matter is you're already seeing a lot of patients with it. You may be aware, you may not be, but you might as well treat them rather than struggle with them. Actually, treating a person with buprenorphine is super easy. It's very effective. It is amazing how easy it is to use. Here's the DSM-5 criteria. Just wanted to throw it up there to make sure everybody knew. Taken in a larger amount for longer than intended, persistent, unsuccessful desire to cut down. They spend a lot of time obtaining them, craving them, a lot of money. Recurrent use causes failure to meet obligations, continued despite negative outcomes, important activities given up, recurrent use despite knowing that you're at risk for overdose death, and development of tolerance and withdrawal. Honestly, most of the people, I think that those of us who use it see are really in the severe category by the time they come to you. Certainly people, and there is, as John talked, there's that intersection of pain. Those people are often more in the mild to moderate range. So what do? Engage in an empathetic, frank discussion, outlining your observations of their use of opioids. Needs to be non-judgmental. These patients are on a terrible treadmill of withdrawal and seeking the medication. They have two states. They're either under the influence of the drug or they're in withdrawal. They have no other way to be. You can talk with them about helping them get off of that rat race of trying to find medication, as well as markedly reducing their risk of death by overdose. Why does addiction occur? The real quick review, synthetic opioids bind really tightly to the mu-opioid receptors in the brain, and they release a greater than necessary amount of dopamine. And addiction-prone people feel terrific. Almost everyone I've talked to, when they say they took their first opiate, they feel great, better than ever. I think it's almost a diagnostic test on who would become addicted. You know, if I've ever had an opioid for any kind of surgery, I hate it. I hate how it makes me feel. I'm not going to be addicted. But boy, someone that says they feel good, they are a sitting duck for it. And it can occur quickly. As we know, addiction can occur in as short a time as a week. Tolerance occurs because over time, the brain recruits more mu-opioid receptors, which increases the amount of opioid required to gain the same effect. And the heartbreak of opiate addiction is that those new receptors don't ever go away. So you end up with this brain loaded with receptors that are crying out for their drug. Withdrawal occurs because the receptors are empty. We all know the symptoms: nausea, vomiting, diarrhea. There's a long list. I do think, you know, some people manage to gut it out and get through the acute withdrawal, but I think even if they do that, there is a chronic abstinence syndrome where they just don't feel right. They're irritable, edgy, they don't sleep well, and even those people will benefit from treatment. Buprenorphine works. Again, this counts for methadone and Suboxone, the combination, all of that. But it's a partial agonist to the mu-opioid receptors. So it sits in the receptors and keeps it busy, but it doesn't activate the receptor. So the person does not get high. And also there is no recruitment of new receptors. So at least it stops that process. Okay, I want to talk a little bit about how to start it in your busy clinic, because it does feel daunting. And I don't know what training all of you have taken, but when I went off to Omaha in 2008, they made such a big deal about how, you know, to start Suboxone, the person had to come into your office and you had to observe them take it under the tongue, and then they were supposed to sit for 2 hours. And oh my word, I mean, that is just simply not necessary. And it was very daunting. And, you know, the first time I started it was for a woman who'd gotten addicted to her husband's fentanyl. And I no matter what I did, I couldn't get her off. He had cancer. And so I went to Omaha, took the class. I had her in. I mean, it was like I was preparing for open heart surgery. I mean, everyone's on standby. I mean, we were all a nervous wreck. It was a non-event. Things went well. I rapidly, what I'm going to tell you is a process I developed over the course of 14 years that has worked really beautifully for me. So first of all, if you decide you're going to do this, I really think you need to bring your staff alongside of you, educate them about the problem. Stigma is huge. Your employees, people who work with you, have encountered patients with OUD. They encounter them day after day, and they struggle with them because you're not going to refill early. You're not going to refill a lost prescription. They are burnt out and frazzled with dealing with people with this disorder, and they are going to say, oh my gosh, we don't want a steady stream of these people, quote, these people in our clinic, what are you doing? There is an article that I think is absolutely magnificent by Jennifer Vielander, who is a psychiatrist. It is in the 2018 Oxford Journal. It's listed there. She talks about the rationale, the science, and misconceptions. And I have to admit that I have copied out that article and I give it to my patients and their families because it is magnificent. It talks about the, how it works, why it works, but the misconception section is fabulous. And I'm going to go through that real briefly with you because we've all had these. I bet we've all had these misconceptions. Number one, Suboxone just substitutes one drug for another. Well, not true. It's a medication. You are treating OUD like you treat diabetes. You're giving them a medication to put in empty receptors. It improves their physical and mental health. It decreases their risk of overdose. It helps also prevent HIV, Hep C, other infectious diseases, and of course, death by overdose. Misconception number two, it's a failure of willpower. Not so. Addiction is a medical disease, not a moral failure. And once you understand about those empty brain receptors, it's easy to see why it's not something they can just simply quit and be fine. Misconception number three, it's incompatible with 12-step programs. That is not true. However, you do have to be careful. Sometimes, the 12-step community is embracing it more, but it's certainly not uniform. And I want people to be involved in 12-step programs because I think they're very powerful. If I know kind of which one they're going to or the philosophy of that one, I sometimes just tell my patients, don't tell them you're on Suboxone, because there is some misunderstanding and these same misconceptions in that community, because that community, that whole 12-step thing was born in abstinence. And so there's not always perfect understanding of this. Patients can get high on Suboxone. Not true. If they're opioid dependent, it will not stimulate their receptors. Now, do people mix it with other stuff? Do they get in altered states when they mix it with things? Yes, they can. But they're safe to drive. They're certainly safer to drive with Suboxone than coming down the road loaded up with 100 milligrams of oxycodone. So it is fine for them to go about their daily activities. And misconception number five is patients will just sell their Suboxone. Well, yes, that is true. Sometimes they do. Studies have been done. The rates of diversion for Suboxone are similar to the diversion of antibiotics, both of which is 20%. It is also true that you will have many patients who come to you saying, I have bought Suboxone off the street. It works so well. I would like to get this legitimately and quit having to do that because it's very expensive off the street. And a study said that 64% of opioid users reported buying off the street to avoid withdrawal. Okay, those are the misconceptions. We'll go back to starting this in your practice, but I cannot over recommend that article because it is fabulous. Okay, so if you have the discussion with the patient and they want to go ahead with this, have them come to you in mild withdrawal if possible. They don't have to be ragingly sick. You just want to have them just kind of starting out on that where they're starting to feel bad. do your routine HPI and exam, discuss the treatment options. I recommend starting with plain buprenorphine. It's cheap, it's simple. There are a lot of different forms now, Zubsolv, Suboxone, and all of those things are fine, but buprenorphine is really pretty cheap. Okay, so what my routine was, once we did all our exam, figured all our stuff out, is that I would say, okay, you're going to take 4 milligrams of buprenorphine under the tongue. That's half of an 8 milligram pill, which is what I prescribe. I would have them take it under the tongue. When they started having withdrawal symptoms, I would have them take another 4 milligrams. This can be as soon as a couple of hours. I would have the patient do that throughout 48 hours and keep track of their dose and frequency. And then I would try to see them within about 48 hours if possible. I mean, you can be a little flexible with this, but the point is you just want a couple of days for them to figure out what is the amount that keeps me out of withdrawal. I would prescribe 10 of the 8 milligrams, make an appointment to see them in 48 hours. I always love, if possible, to get family, significant others, people concerned about them involved if the person is willing, because they're going to be important. They need to understand what we're doing and understand, you know, how Suboxone works and why it's important, at which time I give them that article. So then at 48 hours, I'd go through the patient's log and decide on the appropriate dose, answer family member questions if they're present. Then I want to see them in about 10 days. And based on how much they're using, I'd make an appointment to see them in about 7 to 10 days, whatever works out with their and your schedule. At 7 to 10 days, we review how things are going, adjust dose accordingly. At that time, I think they're stable enough. You know, people are sick when they're in withdrawal. They are sick, they're scared. In my opinion, it's not the time to have the big discussion about HIV and all that junk. Wait until they're cleared up, thinking more clearly. It is also time to start addressing other mental health issues. Often there are dual diagnoses, but again, when they're under the influence or in withdrawal, you're not going to get anywhere. And furthermore, you're not going to know what their native state is until they sober up, until they get so that they're not under the influence. So you could start your testing if you want to, start discussing getting involved in a recovery community of some kind. There are a lot of online things that are available. Discuss the resolve to remain free of substances and what to do if relapse occurs. And I should probably say when relapse occurs, because there's not many people that don't relapse. We'll talk about that a little bit later. But if it seems appropriate to you, you can move to monthly appointments then. It depends on the patient's circumstance, how often you want to see them. By the time someone has been on this for a year or so, or 2 years, I mean, you can go to see them every 4 to 6 months. It's whatever you and they are comfortable with. Are there any questions so far? Okay.
I do have a question. Is this standard approach to, you know, starting them on the 4 milligrams and having them take it whenever they start having symptoms? Is that like an algorithm that's available somewhere?
I don't know, because I came to it over the years. I don't know that it is. It is what has worked best for me. Everybody is a little bit different in their requirement. And I just found that it was much smoother for them to figure out their dose than for me to figure out their dose. And so it is kind of a way I went about doing that, saying, look, we want to find the right dose for you. This is how we do it. Okay. So we can talk about that later, but you're welcome.
There.
Here are some things worth John, did you want to say something?
Yeah, this is a very good way to get started, and you'll see it as this series goes. There are different ways to do that also, and you'll probably adopt your own plan, but that there are kind of evolving different ways that you may prefer, but this is a very good one, obviously.
Well, there are lots of different ways, and again, you have to decide what you're comfortable with, but it's what I found that worked best. Most of my people were people who were really, well, I'm saying this badly. They weren't pain people. particular. They were people who had gotten addicted to Suboxone and were using pretty high quantities of opiates. So that tended to be my population as a rule. So, but again, you'll have to develop your own thing, but it sure worked well for me. And I think, people kind of were like, oh, okay, I can figure out what works for me. And we would go from there. Some things to think about. Consider letting the pharmacist know what you're doing. Obviously, when the person comes with a prescription, they're going to know, but it's sometimes nice to have that discussion. You don't have to. Check the PDMP regularly and decide what to do if there's a relapse. Now, I had to get over the gotcha mentality. And I think that a negative result on PDMP is an opportunity to talk with the patient about what's going on. It is important to know what else they're using if you can figure it out. If there is a relapse, is that a reason to throw them out of your program? I think no. I realize sometimes eventually you just have to say, okay, this is not working for you. But it's not perfect, and they're not perfect. And I think a little grace being extended is worth a lot. I talk a lot with patients about what happened when you relapsed, what was going on, how did you feel, blah, blah, blah. You need to make a decision of how you might use urine drug screens beneficially. Again, it's nice to know what other things they're using. They're all going to be using marijuana. I can just tell you that. But the other things you have to kind of decide. It's an opportunity to say, okay, let's get a drug and alcohol evaluation and see how else we might work on these other things. I always go over with them the increased risk of fatal overdose if they decide to relapse. I make sure they understand that if they are going to relapse, for heaven's sakes, do not use the last dose they used of opiates a month ago, because their tolerance will have gone down some and it can kill them. So I make sure they have Narcan, know how to use it. We just have to be frank about this because it can save lives. In my opinion, it's important to be flexible in dosing. Some patients may require higher than recommended amounts. The upper recommended amount is 24 milligrams a day, up to 32 sometimes. There's the whole theory that over 24 doesn't do any good. But honestly, I think you have to really meet people where they are. There's no sense in partially treating a patient. The goal is to have no craving for opioids. And if you undertreat, their risk of relapse is really high. As they stabilize, often you can taper the dose and get down more to that 16 or 24 milligram if you've had to go over it. But I don't think it's a hill worth dying on at first. Get them stable, get them sober, get their life back in shape, and then you can start to trim back. At all times, celebrate the little victories that will occur, a job, a family reconciliation, be a constant and consistent voice of encouragement. These people have burned out their support system usually, and it takes families and people that care about them a while to recognize that they might actually be in recovery. And a lot of times patients are really frustrated and impatient about that. They go, well, I've been sober for a week and they still don't. And it's going to take them a while. And so tell them to just stay the course. It eventually works out, but it does take a while. If you've got someone else in your community that's providing this treatment, at least reach out to each other once in a while, see how it's going. It is important to get past that gotcha mentality. I think you use this, therefore I'm throwing you out. I think it's important to deal compassionately with people in recovery. Many of them, certainly not all of them, but many of them have very, very chaotic living situations. Many of them, by the time they're seeking this treatment, don't have jobs, they don't have stable living situations, they don't have supportive family. It's not easy, and it takes a while for them to get things straightened out and to get their life put back together. There are immensely satisfying success stories with the use of these medications. You will be changing lives for the better. You'll be saving lives. And this will be very gratifying, and people will thank you from the bottom of their hearts over and over. Family members will thank you. Occasionally you'll be disappointed and heartbroken and wonder whether it's all worth it. And that's why support is important. You know, some people just are not ready to do what it takes to stay clean. And that is heartbreaking, but it's just part of it. We're committed to helping you implement this if you're interested, and in any way we can help, reach out to us, and we can give you the contact information. Are there any questions? I do have a case to present, but are there any questions?
We had a couple in the chat, Janet. One person asked about any like certification prior to prescribing, and I put an answer in the chat there. Previously, there was an X waiver, but
Right.
no longer. Amanda put a question in, and it looks like John just answered that in the chat. So Amanda asked, you mentioned high doses of opioids. What is the MME you were seeing with the patients who were using the 4 milligrams?
Well, everybody's different. Again, I think this is where you really have to, I know that there are a lot of those little graphs and charts out, and MMEs equals this and that, but really what you're looking at here is how the patient is responding to that. Some people get in, you know, whether you take 24 milligrams all at once or spread out during the day, theoretically should not matter. But if you're a person who's had to be slipping an oxycodone every 2 hours to stay out of trouble, you're not going to believe that. So sometimes people will take 2 milligrams every couple hours, you know, until you kind of get them over the hump of understanding that this medication is going to work. I think, in my opinion, I think you need to be flexible with that and find what dose is going to work for them, search around to find the dosing interval that is appropriate for them, and work with them. Eventually, as they get further along in recovery, they will start to see that, oh yes, indeed, I can take 2 8s a day and I'm fine, you know. So it really is not such that there's a certain dose for a certain MME, in my experience.
Hey, Janet, can I jump in with a couple thoughts?
Yeah.
As far as like starting patients on the Suboxone, like with the diagnosis, like again, anybody can prescribe Suboxone for substance use disorder. And you went through the DSM-5 criteria, which is really helpful. One of the things that I didn't know initially is that DSM-5 criteria can count for a patient within any 12-month period in their life. And so a lot of times a patient is like, if they've been in jail or incarcerated or they haven't used for a long time and they come to you and they're like, hey, I need help with this. And you're like, well, you haven't been using for so long. Like, it's still a medication that you can start. Obviously, you want to start them on a lower dose than a high dose, but that's a really helpful tip as far as like, you don't need a special waiver, but you do need to diagnose them with the opiate use disorder. So that's one thought. And then again, on the dose equivalents, there's a lot of charts out there, and I totally agree. Like, it's sort of patient specific. One thing that I've found too is the medication is difficult to absorb correctly because it's only absorbed in the mouth. And so a lot of times we tell our patients, hey, no eating, drinking, smoking, before and after, hold it in your mouth. And so sometimes patients will be like, hey, it is or isn't working. And you really got to ask them like, hey, are you taking it correctly and actually absorbing it into your body? So those are a couple of thoughts on that, on the dose equivalent and getting started.
Yeah, thank you. That's very true. Any other questions? Okay, well, let's look at this case. 28-year-old male sees you requesting Suboxone therapy, stating he's tired of the constant stress of trying to obtain opioids to keep from going into withdrawal. He heard from a buddy that you're prescribing Suboxone, reports he became rapidly addicted to oxycodone after a high school football injury where he tore his ACL. I have to stop here and say one thing real quick, is that in all of those patients over all that time, I mean, I can maybe list 2 who got quote addicted because they bought it from somebody and took it in the first place. Almost everybody had some surgery, had their wisdom teeth, their knee, their this, their that, got started at the hands of us after some injury or illness of some kind. After surgical repair, he was prescribed oxycodone for post-op pain. He reports that he instantly felt better than he ever had before, and he was able to convince various doctors to continue prescribing for other minor pain issues. By the time he presents, he's using 100 or so, or whatever he can lay his hands on, which includes some fentanyl. A lot of people use heroin now. It's cheaper than opioids. He reports that he recently suffered a near overdose, but a friend found him in time and was able to revive him. He states his wife doesn't know, but is wondering where all the money is going. He knows people who have died of overdoses and is afraid of what might happen to him. He was a walk into your clinic. He used fentanyl last night and is in early withdrawal. So let's discuss what steps you might take. Anybody have any thoughts about this whole business? Well, what I would do, I will tell you, is I would have this frank discussion with him. I mean, he is in withdrawal now. He is in trouble. He is at high risk of death by overdose. He is using undocumented medications off the street. I would have that discussion and start him today. I think I would probably do my same routine that I outlined before. You know, he is a motivated person. He understands that the risk is high and he's looking to change his life. So I would start him off. You know, everybody's a little different with what their insurance coverage is. However, given all of that, that's sometimes an uphill battle. So I'd again probably start with plain buprenorphine because it's cheap. Once you find out if they have coverage for something, you can go to the sublingual strips. I mean, they're nice, they dissolve quickly, but they're more expensive. So you just kind of have to feel your way around through that. Does anybody, John, do you have anything to say about that case?
So the motivated patient who shows up at first, and yet he's a young guy, he quickly, you know, ran into trouble. I'd want to explore a little bit where he was coming from the standpoint of his understanding of kind of the commingling of the two. Why buprenorphine is going to be better for him with respect to the symptoms that originally brought him to his opioids. And I think a lot of times we couch this in terms of, well, you know, you got in trouble because you necessarily needed medication because you tore your ACL, which is, as we know, kind of a fool's errand. So I'd want to take his desire to start up and give him some ammunition to stay with the treatment should he run into some bumps in the road with dosing or side effects, and kind of explain to him that this medication will accomplish the purported initial goal while it saves him from the risk of OUD.
Right.
You can pre-arm patients, I think, with a lot of reasons for success if you're thinking of it right way and communicating.
Yeah, yeah. And
You know,
these people,
sorry,
go
I
ahead.
have lots of thoughts about fentanyl, but I don't know how much you want me to jump in, but let me give you a couple of cents on it. So fentanyl in different locations is different. So like when we're seeing fentanyl on the coast, like the stuff is so potent that patients can only go sometimes like 4 to 6 hours before they start getting really sick. So that can be really difficult to initiate someone. And so I just say stuff like that of like, hey, we're available if you run into patients like that because we want to consult with you. But a lot of times if patients are actively using fentanyl, we do really want to encourage them, at least from what we see in our practice, of like a 24 to almost 36 hours of abstinence. And sometimes we can talk about like some withdrawal medications. But if somebody takes Suboxone too soon after they've used their fentanyl, and we'll probably get into this more, but the danger is the precipitated withdrawal. And the precipitated withdrawal is so miserable.
It's super bad. Yeah, it's super bad.
Yeah.
Yeah, but if you use plain buprenorphine, you don't run into that so much, which is why I do that, you know, because you don't have such an issue.
I think it's the other thing to think about is we'll still start with 2 milligrams because I don't think it's the naloxone in the medicine that gives them precipitated withdrawal. It's the lack of filled receptors. So I still will take kind of a cautious approach if I'm going to start somebody with, you know, in the traditional fashion, and I give them 2 milligrams and I wait for 20 minutes to make sure they don't start getting edgier. And then, because you can back out a precipitated withdrawal at 2 milligrams where you have a little harder time at 4. And so if I'm uncertain about their count score, I'll just give them the tiniest bit and go slower.
That probably brings up my next case that I'm going to present and then have John talk about. So a 66-year-old female presents for follow-up chronic pain management. She's seen you for years for severe chronic back pain. She's been managed with NSAIDs and oxycodone 10 QID. Lately, she's been complaining that her pain is not adequately controlled and she feels that her medication needs to be increased. You've been noticing for some time that she's been calling in for early refills and having some unusual cases of lost medication. You decide to take this opportunity to discuss transitioning her to buprenorphine therapy, and how would you proceed? So this is a slightly different person. This is a person who, they're not getting their medication. They're not using huge, enormous amounts, but they're also starting to kind of, they've developed tolerance clearly. So I'm going to ask John to talk about this, because this is a chronic pain person, and the transitioning to buprenorphine can be very effective.
So let me start that out by asking some questions of folks. If anyone on the call, does anyone want to ask questions of the patient to me to start before we kind of, and I'm sure a lot of us have seen this kind of patient. They're just basically gradually falling into the abyss with what they think is therapeutic use of opioids, and they're accumulating aberrant behaviors is what Janet's presenting. They're using more, they're running out, they're not really fully open about what's going on with that, and they're just not succeeding, but they believe themselves to be managing the symptoms of chronic pain. Does anyone have any questions they want to ask of me or Janet about that patient that we would want to learn about before we start talking about what to do? And if not, I can.
I would want to know if she. I would want to know if she's diverting at all.
Okay.
Does she have a family member that's using? Is that why she's doing early refills?
So you're
I don't see that often, but I do see it.
What we see is about half the number of people divert as misuse, if even that high. But that's a good question to know. You're trying to figure out if in fact she's using more of the medication than we prescribed, or is she doing something else with it, which is obviously a different kind of clinical case. Good question. Anyone else?
We had one in the chat from Naomi. She asked, do you have each patient agree and sign a contract to treatment, or does that not make a difference?
Well, yep. It's first of all, it's an agreement. It's not a contract, right? We're not providing services based on somebody doing something. What we're doing is we're saying these are the set of circumstances that indicate safe use, and these are the set of circumstances that indicate not safe use. And so that's an important feature. But let me get to some other things that I'd want to know. So we've got a patient who is using medication in a way that's sort of accelerating and losing functional status. So I'd be asking, what's the background of this patient? Is there a family history or personal history with issues with respect to use disorder? We know that the different kind of the tripod of things that can affect development of a use disorder is trauma, is genetics, and environment. And so the trauma can often be thought of as the physical injury that started it, but it may be something much deeper and more important. We want to know what the family dynamics or the person, the genetic predisposition for this is, as well as those kinds of risks. So I'd be doing something like a SOAP or an ORT to kind of assess where are we with respect as a screening study for the development of use disorder. And then I'd be looking for objective data that says there's an aberrant use pattern, because Janet talked about she's running out of refills, so that's a self-dose escalation. Has this person been in the ER? Does this person become less functional? Have they lost their job, or are they having family strife? All of these are more subtle indications of the accumulation of a use disorder that, I will make the prediction that most of us, when we're prescribing this medication for patients, we're not doing it just because patients come to us saying, I've got a problem with opioid use disorder. They're going to come to us saying, hey, these medications aren't working. I need more of them. Why don't you care about how I feel? And we need to learn the background of that thinking so that we can reverse it into a more functional status. So those are the kinds of questions I'd be asking of this individual. And then I'd be heading off in a different direction, like Janet already teased us with.
I'm going to interrupt just real quick, and then I want you to finish. A thing that I often found with these, when you have a person that's coming to you who has been on chronic pain medication, it's a little different situation, and they really believe that their pain is worse. They think my pain is worse because I am having to take more medication, therefore my back pain is worse. And so a lot of education goes into saying, you've developed tolerance for the medication. And what's happening, and I think what happens is that then they start to go into withdrawal and everything hurts worse. And they go, oh my gosh, I run out of medicine and I'm just a mess. And they don't understand that it's really partially withdrawal that's happening. And so a lot of education goes into that chronic pain person because they don't believe it. They think their back pain is worse than ever. And so I will, John, carry on.
Well, so this is a teaser for our next discussion, and we'll be talking about that. But fundamentally, what we're going to want to communicate to you folks is that the physiology of chronic pain and the physiology of substance use disorders, not just opioid use disorders, but other ones, is intermingled, and it's more of a continuum than something that's separate. So what we find is these medications that are thought of as less potent to manage the symptoms of chronic pain are more potent at reversing the physiology, because the physiology that brings somebody to a long-standing chronic pain complaint that's gradually losing an effective treatment with acute pain treatment happens to be the same physiology that is amenable to treatment with buprenorphine. So the communication is fundamentally, if we want to make your pain feel better, we need to switch into this medication that you have been taught is a partial agonist rather than a full agonist. We have developing and accelerating studies that show it's much more effective at treating chronic pain. Todd, do you want to comment on that? Now he's got to find his mute button, I know. Well, I'll let him, you butt in when you want. But so what and the neat part about this is that as the one trick with buprenorphine initiation on individuals that have this sort of indolent dependence physiology developing is that we can initiate it in a different way to find the most therapeutically useful dose. So we don't have to go with the, quickly go to the 4 milligrams like you do, as Ed would suggest, with somebody who's getting higher levels of medication and is at risk of overdose and so forth. This individual might be a more gradual risk to that, so that we'll commonly start with 1 milligram and see how they do. And it also, with that technique, obviates the need that we don't necessarily have to say, I need you to be in a moderate level of withdrawal before we initiate. We'll start low levels of buprenorphine and then phase out what we would say the legacy opioids are. And the individual just sort of by hook and by crook finds out that their pain symptoms are better, and you stepped away from the opioids without me even knowing it. So it's kind of a neat way to align yourself with the patient, and you're treating what they think is the primary issue, which is chronic pain, when you know that the primary issue may be that their life's at risk, given the idea that they're using a medication that can give them adverse effects without therapeutic benefit.
Thank you. Any other questions for John? And it is a teaser for next presentation, because we're going to talk specifically about that, because there is this huge population of people just like this who, they're not, they don't view themselves as having a problem, but they have developed tolerance and they are unable to go without their medication. And so it's an opportunity to get some of that stopped as well. Let's see.
We had a question in the chat. What about alcohol use disorder and buprenorphine?
Well, if you're talking about treatment for alcohol use disorder, there's, Vivitrol, which works beautifully.
My fault.
Okay, that's all right. So, that's certainly a possibility for that. There's no contraindication to them using buprenorphine for opioid use disorder if they also drink alcohol. I mean, that's not a contraindication.
Todd, do you want to talk to us about the use of buprenorphine with alcohol?
Yeah, so I think there's several things that are kind of important, worth mentioning in the context. First off, the alcohol use and tobacco use are still our big problems in Nebraska, more than anything. In terms of substance use disorders, probably methamphetamine is the quiet one. So we can't overlook comorbidity and co-occurring kind of substance use disorders, which are really made worse by untreated mental illness or psychiatric illness. So treatment outcomes, and I'm getting to the alcohol piece, but I want to include a couple other things. Outcomes are largely influenced by the idea of getting treatment or working in something towards your substance use, as well as treatment of coexisting or co-occurring, if you will, mental illness, in addition to two other major components, and that is replacement activities in your network, so your support system, and we can't overlook those things. So the single most effective kind of treatment for moderate to severe opioid use disorder are either an agonist or a partial agonist. As potency goes up, unfortunately, buprenorphine is going to be less effective, and we already know that from what's happening kind of across the country with potency of either fentanyl or carfentanil. So that's going to present a new set of circumstances for us. Nevertheless, it's important to kind of treat the existing and comorbid kind of problems that go along with to maximize your chance of dealing with opioid use disorder. When it's alcohol, right, you have to think about a couple things besides what I've mentioned in treating mental illness or the substance. And one is it what's the primary diagnosis? And it doesn't always work this way, but sometimes when you treat the primary problem, the secondary issues get better as well. And so addressing, if it's an OUD, addressing that, and you may find their use of other substances decrease as well. If there truly is kind of a opioid and an alcohol problem, then you have to take a look at what are the options, because you don't want to give somebody an antagonist that's on an agonist that'll put them into withdrawal, right? And so you have to be very careful about using, you don't want to start somebody on Vivitrol without trying oral medicine first, right, to make sure they can tolerate it. But if they're on an antagonist and an agonist, you're going to precipitate withdrawal in many cases, or there's going to be competition at the receptor, which is going to make them often feel worse. So naltrexone is not always the greatest option for, and certainly for somebody that's on buprenorphine. We don't have great kind of pharmacological options across the spectrum for substance use disorders, with the exception of the three things that can be used for opioid use disorder, primarily three, and that's buprenorphine, methadone, and naltrexone. Now, if somebody has an alcohol use disorder and they have a opioid use disorder, the starting point probably is to use an antagonist, And that would either, that's again, naltrexone, because there's some benefit for it with alcohol use disorder as well as opioid use disorder. And then you can switch to a longer acting, if they tolerate it, Vivitrol, and manage them on, or attempt to manage them on Vivitrol in this context. And there's where your psychosocial treatments may come in, and harm reduction is really important in this context as well. So trying to reduce the amount that they're using and improve functionality. So that's kind of how I would approach it. I would not probably use buprenorphine. If both were there, I would use naltrexone oral, make sure they can tolerate it, and then try Vivitrol. Some of the other thing you could, if you're say, well, buprenorphine is really an important thing, and you feel like you wanted to use a medication, you could use the old adversive agent, disulfiram or Antabuse, and that's still done some. And acamprosate is, it doesn't work that great for most people. So Camprol or acamprosate for alcohol use disorder, you're going to probably struggle with limited effectiveness. So biggest bang for your buck is treatment of coexisting psychiatric problems, because relapse is much higher, and then addressing in kind of a thoughtful capacity whether you're going to use naltrexone or how you're going to proceed with that, in addition to the two other things that I mentioned, and I'll repeat those, and that's replacement behaviors and activities, and strengthening that support system for those individuals. So those four components are particularly key across the spectrum.
Question for Vivitrol. So I recently had a patient who I was managing for cancer pain with new progression, who was long standing on Vivitrol for alcohol, misuse prevention. And that was something where they needed opiates for their cancer pain. And I couldn't find any sort of guidance on how to adjust my opiates while on the Vivitrol and what kind of effectiveness I could expect.
You're not going to be able to get effectiveness. That naltrexone, that's in large part how naltrexone will work, in terms of it's kind of continually administering an antagonist. So in that situation, I would step away from the naltrexone, and that might be an instance where you would consider buprenorphine, because it can at least potentially mitigate provide some of the same relief that the naltrexone is for the alcohol, and it can also provide analgesic efficacy for somebody with ongoing pain. It might be a dicier way to go, because you'll have to watch for side effect development and effectiveness, but ultimately you're not going to be able to succeed with opioids plus naltrexone. It won't work.
If it's okay, can I ask one more question, just because I have the experts on the line? So
That's what we're here. Yeah.
I have a patient that I'm managing for chronic pain who is having side effects of severe constipation with his MS Contin. And so we switched him to buprenorphine. So he was on just 1 milligram, and since he's started, he's still having trouble with the constipation, and he's finding he actually feels more dizziness with the buprenorphine than he did with the MS Contin.
Can you talk about what the MS Contin dosing was, and then what your relevant buprenorphine dosing is? Do you happen to remember?
Sure. So he was on low dose. So he was 15 milligrams of MS Contin BID with, I think, like 2 or 3 hydrocodone 5s throughout the day.
Okay. So a great question. That's a fantastic question. We see this all the time. So fundamentally, the one trick with buprenorphine that I would say is that there is a translation, there's a kind of a scale when you're transferring a patient from who's on opioids without use disorder and somebody who has use disorder. That is, I tell our nurses that when you're transferring from morphine to buprenorphine for chronic pain treatment without use disorder, you're kind of in the microgram range. And when you develop use disorder, you get into the milligram range, if you will. So what you inadvertently did with that is you probably gave the patient a relative overdose of the buprenorphine compared to the morphine that they were on prior. And you didn't solve the OIC issue. You did a good thing. I think you're going to get a patient who's much more happy. And what you're noticing is if you try to go to Belbuca or Butrans, which are the microgram doses of buprenorphine, it's more expensive. But you could use the half-life of buprenorphine to your advantage, and you could tell the patient, I want you to take 1 milligram every 36 hours. If you can get them to do that, and they'll have the dizziness or the opioid type side effects go away, and they'll still have more analgesic effect than the old morphine because of all the things that we'll talk about in 2 weeks. And the other thing you can do is you can simply treat the opioid-induced constipation with a Symproica or a Relistor or a Movantic, and just use that 3 times a week, and you'll get the reversal effect in the gut without affecting what's going on systemically. But great therapeutic choice. You just probably inadvertently over-translated somebody into a higher dose of buprenorphine.
Yeah, I actually started him with a micro induction with Belbuca.
Yeah.
And so we
Yeah.
and I was up to, I want to say, somewhere between 300 and 450 micrograms BID with the Belbuca before switching on to the buprenorphine. And he was doing really great on the Belbuca. The reason we couldn't stay on it was price. He couldn't afford the Belbuca. And so that was the reason for switching to the Buprenorphine.
So just try 1 milligram every 24 hours, or I've had that very same patient just have the same problems at 1 milligram every 24 hours, and I said go to every 36 hours, and their daughter set up a clock where they go 8 in the morning one day and 8 at night the next night, and all the side effects went away, and we just used the long-acting half-life of buprenorphine to the advantage, and we didn't have to pay those high Belbuca prices for somebody who can get a generic.
Awesome, thank you.
Yeah, good question.
So I know we're at the end of the hour here. There's one more question in the chat that maybe we can get to, but if folks need to hop off, you're welcome to hop off. I'll follow up with an email later today about how to get that certificate. There was a quick question. I think Todd kind of addressed it, or maybe John addressed it, but can you talk about the difference between naltrexone and buprenorphine?
Yeah, that was my question, and he was just starting it when I typed it. So I think he covered it. Thank you. Yep.
Okay, great. Well, thanks for being on, everyone, and we hope to see you all in 2 weeks. John's going to be talking about how to deprescribe and make your patients happier. And and like folks mentioned, if there's a need for additional consultation, probably the best way is just to reach out to me. You all have my email, and my phone number's in the email, and then I can connect you with one of our hub team experts. So thank you.
Thank you.
Good job, Janet.
Thanks.
Yeah, thanks,
Great.
Janet. That was great.
Great job, Janet.
Thanks, everybody.
Thank you.
Thanks, Janet.
Thank you.